Hello and welcome to the first of this mini-series of screencasts on the subject of the pharmacology of antihypertensive drugs. This first presentation will hopefully set the scene for those that follow, and I'm going to start by giving an overview of what's meant by the term hypertension, and then we'll briefly review the mechanisms involved in blood pressure control. By the end of this screencast, you should understand what's meant by the term hypertension, and you should understand the basic control mechanisms that are in place and are involved in blood pressure homeostasis. You'll also be aware of the various classes of antihypertensive drugs, the pharmacology of which we will be discussing in the subsequent screencasts on this topic. So we'll begin by looking at what is meant by the term hypertension. Currently, the World Health Organization defines hypertension in patients who are under 50 as a resting blood pressure above 140 millimeters of mercury systolic and or above 90 millimeters of mercury diastolic. In over 50s, resting blood pressure would be above 160 millimeters of mercury systolic or above 95 millimeters of mercury diastolic. So what are the health problems associated with patients who have hypertension? Hypertension is a significant and preventable cause of premature morbidity and mortality, and as you know, is a major risk factor for ischemic and hemorrhagic stroke, myocardial infarction, heart failure, kidney disease, cognitive decline and premature death. Hypertension is known as the silent killer because of the fact it's so often asymptomatic. And untreated hypertension is particularly associated with a progressive rise in blood pressure, and this can cause extensive vascular and renal damage and result in a treatment-resistant state. The health risks associated with hypertension increase in accordance with the increase in blood pressure. With each 2 millimeter of mercury rise in systolic blood pressure associated with a 7% increased risk of mortality from heart disease and a 10% increased risk of mortality from stroke. So what are the causes of hypertension? Primary or essential hypertension accounts for 95% of all cases. The underlying cause of the hypertension is unknown, but it's associated with increasing age, particularly in patients aged 40 and older, with obese patients, with patients who are physically inactive, smokers, and those with moderate to high alcohol consumption. And there also appears to be a genetic predisposition with instances of hypertension occurring in families. Secondary hypertension accounts for the remaining 5 to 10% and is usually caused by renal disease, which activates the renin-angiotensin-aldosterone system, or endocrine disease such as steroid-secreting humours in the adrenal cortex or adrenaline-secreting tumours of the adrenal medulla. As the cause of hypertension is unclear in the vast majority of cases, treatment cannot be directed at a particular underlying mechanism, and most antihypertensive drugs are acting as vasodilators in one way or another. Before we look at the mechanism of action of the various antihypertensive drugs that are going to be discussed in this series, I think it's important that we spend a bit of time reminding ourselves of the basic physiology of blood pressure control. In that way, we can better understand how the action of the various drugs work to reduce blood pressure. So we'll start with the basics. Blood pressure, i.e. the force exerted by blood on the walls of the arteries, is determined by both the cardiac output and by the peripheral vascular resistance. To make sure we understand this, we can think of the hose pipe analogy. So by turning on the tap further, increasing the flow of the water, we're, in our analogy situation, increasing the cardiac output of the system. By squeezing the hose, this would be increasing the resistance to the flow, which would be analogous to our peripheral vascular resistance. Both actions, i.e. turning the tap on further to increase the flow of water, or squeezing the hose to increase the resistance, result in increasing the pressure of the water. For the cardiovascular system, the flow is controlled by the heart. Flow can be increased by 1. Increasing the cardiac output by either increasing heart rate or stroke volume, or 2. Increasing the blood volume. Conversely, flow is reduced by decreasing the cardiac output or by decreasing the blood volume. The artery controls resistance, so when the artery contracts or vasoconstricts, resistance to blood flow is increased, and hence there is an increase in blood pressure. When the artery relaxes or vasodilates, the resistance to blood flow is reduced, and hence there is a decrease in blood pressure. In a healthy person, blood pressure is controlled within fairly narrow limits due to a series of physiological reflexes that are triggered by acute and chronic changes in blood pressure. There are both short-term and longer-term control mechanisms. We're going to spend a little bit of time reviewing how these systems interact to maintain blood pressure, starting with the role of the autonomic nervous system. The autonomic nervous system is a division of the peripheral nervous system. It works unconsciously and is regulated by the hypothalamus. It consists of the sympathetic, fight or flight, and the parasympathetic, rest and digest. The autonomic nervous system regulates arterial blood pressure in several ways. In the heart, the sympathetic nervous system acts mainly via beta-1 adrenoceptors to increase myocardial activity and heart rate. This generates an increase in cardiac output and increase in blood pressure. Conversely, an increase in peripheral nervous system tone will have the opposite effect, i.e. reducing heart rate and hence reducing cardiac output and blood pressure. In arterial resistance vessels, sympathetic nervous stimulation produces vasoconstriction through stimulation of postsynaptic alpha-1 adrenoceptors. Arterial vasoconstriction raises blood pressure. In the healthy heart, cardiac output is maintained by an increase in cardiac contractility via beta-1 adrenoceptors. In venous capacitance vessels, sympathetic stimulation of postsynaptic alpha-1 adrenoceptors produces venous constriction, which increases venous return to the heart, raises cardiac output and increases blood pressure. The autonomic nervous system is responsible for the immediate regulation of blood pressure. Change in blood pressure is detected by baroreceptors or stretch receptors in the aorta and carotid arteries. When blood pressure rises, the stretch detected by the baroreceptors increases afferent nerve impulses to the coordinating area in the medulla, which controls the autonomic outflow to the cardiovascular system. The increase in afferent signals inhibits sympathetic nervous system output and increases parasympathetic nervous system outflow, returning the blood pressure to normal. The opposite happens when blood pressure falls. Any change in mean arterial pressure triggers an autonomically mediated baroreceptor reflex that influences the heart and blood vessels to adjust cardiac output and total peripheral resistance in an attempt to restore blood pressure to normal. As with any reflex in the body, the baroreceptor reflex includes a receptor, an afferent pathway, an integrating centre, an efferent pathway, and effector organs. This system is hence able to detect and react to changes in blood pressure within seconds. If you feel you need a refresher on the ligands and receptors involved in the autonomic nervous system, you may want to take a look at this YouTube video. It's only 12 minutes long, but it may help you to understand how some of the pharmacology coming up in the next 3 screencasts. I've produced a short URL version here for you to find the video fairly easily. So we've looked at the fast responses to change in blood pressure, and now we'll look at the slower compensatory mechanism for a reduction in blood pressure, which is provided by the renin-angiotensin-aldosterone system. This plays an important role in regulating blood volume and systemic vascular resistance, which together influence cardiac output and arterial pressure. As the name implies, there are 3 important components to this system: renin, angiotensin and aldosterone. Renin, which is primarily released by the kidneys, stimulates the formation of angiotensin in blood and tissues, which in turn stimulates the release of aldosterone from the adrenal cortex. Renin release is stimulated by renal artery hypertension, i.e. that caused by systemic hypertension or renal artery stenosis, by decreased sodium delivery to the distal tubules of the kidney, or by sympathetic nerve activation, acting through beta-1 adrenoceptors. Renin is a protease that acts on the circulating renin substrate, angiotensinogen, to release the decapeptide angiotensin 1. This is further cleaved by angiotensin converting enzyme, otherwise known as ACE, to the octapeptide angiotensin 2. Angiotensin 2 acts at specific AT1 and AT2 receptors, which are found in various tissues. Its action at the AT1 receptor causes potent vasoconstriction. Aldosterone acts on the distal tubules and collecting ducts of the nephron, increasing reabsorption of ions and water in the kidney to cause the conservation of sodium, secretion of potassium, increase in water retention, and hence increase in blood pressure and blood volume. When dysregulated, aldosterone is pathogenic and contributes to the development and progression of cardiovascular and renal disease. Aldosterone has exactly the opposite function of the atrial natriuretic hormone secreted by the heart. The third and final system involved in blood pressure homeostasis is the role of the tonically active endothelium-derived autocoids. The autocoids are essentially hormones which act locally. Endothelial cells produce several vasoactive chemical factors, among them endothelin and nitric oxide, which work in opposition. Nitric oxide dilates blood vessels, while endothelin is a powerful blood vessel constrictor. In normal healthy states, the body maintains a balance between nitric oxide and endothelin, but in certain disease states, endothelin is produced in excess, which may contribute to high blood pressure and heart disease. Okay, so that concludes a very basic and brief overview of blood pressure control mechanisms. Now we can move on to look at the drugs used to treat hypertensive patients. We'll be looking, as we do for all drug classes, at those included in the British Pharmacological Society core curriculum for medical students. You may wish to have a copy of this yourselves, so I've included the web link to the full paper, and that's on the slide. In the screencasts that follow, we're going to be looking at the pharmacology of the various drugs involved in reducing a hypertensive state. So we'll be looking at the diuretics, the beta adrenoceptor blocking drugs, or beta blockers, the calcium channel blockers, the nitrates and potassium channel activators, and also drugs affecting the renin angiotensin aldosterone system, so the ACE inhibitors, angiotensin 2 receptor agonists, and also the alpha adrenoceptor blocking drugs. It's helpful, I think, to consider the drugs as belonging to one of three broad classes, and we'll start by looking at those which interfere with the action of the sympathetic nervous system. So this is the final slide of part 1 of this series of screencasts. Please next view part 2, which will be looking at antihypertensive drugs acting on the sympathetic nervous system. Thank you very much.